The surgeon tells you to drink it, not as punishment, not as a last resort, as medicine. And for most of the last 2,000 years, inside the most respected medical traditions on earth, that instruction made complete sense. Here's the logic behind it. You have just been cut open. The year is somewhere in the 1600s, the room is cold stone, and the man who operated on you has already moved to the next patient. There is no sterile dressing, no intravenous line threading fluid back into your arm, no morphine, no antibiotics, nothing between your open flesh and the open air, but a rag that has already touched someone else. What you have is a body that has just spent everything it had keeping you alive on the table, and now it has to find its way back from that edge on its own. The problems come in a particular order. First, the dehydration, because blood left the table with you and nothing clean came back in. Then the fever, which in a room like that is not a symptom so much as a sentence, because whatever entered the wound during the cutting is already settling in. Then the pain, constant and dull and wrong in the way that makes you understand the body is doing something catastrophic and slow. And underneath all of it, a specific terror that every surgeon of that era knew by name. Blocked urination? The patient who could not pass water after surgery did not usually survive it. The kidneys shutting down, the bladder silent, the body folding inward. That silence was the sound of the end arriving. Modern recovery has erased all of this so completely that you cannot feel it from where you're sitting. But picture your own body in that room. The thirst alone would make anything seem worth trying. So what was worth trying? For centuries, the answer was already inside you. Physicians did not look at urine the way you do. You look at it as a byproduct, something the body has already decided to discard. But the pre-modern physician looked at it as a report, a detailed, legible summary of everything the interior of the body was doing that he could not otherwise see. The color told him which organ was stressed. The smell told him how far a fever had progressed. The sediment settling at the bottom of the flask told him whether the crisis was building or breaking. He held it to the light the way you hold a document. He tasted it when the color alone was not enough. This was not guessing. It was a structured diagnostic system with its own grammar and centuries of accumulated notation behind it. The practice had a name: uroscopy. By the medieval period, it was so central to European medicine that the image of the physician holding a glass flask of urine up to the light had become the visual shorthand for medicine itself, the way a stethoscope works now. A document from the 11th century physician Ibn Sina, whom European scholars called Avicenna, laid out the reading of urine across chapters of his canon of medicine with the same systematic weight he gave to pulse and fever. 20 colors, multiple consistencies, each combination pointing somewhere specific inside the body. The canon was still being taught in European universities in the 1600s. If urine was the most legible text the body produced, then the body was already communicating through it. And if the body communicated through it, the distance between reading it and using it was shorter than you might think. Humoral medicine supplied the rest of the reasoning. The body, in this framework, ran on 4 substances in dynamic balance: blood, phlegm, yellow bile, black bile. Disease was imbalance, cure was correction, and correction meant reintroducing what had been lost or purging what had built up past its proper proportion. Urine fit this framework with a kind of internal consistency that was hard to argue against from inside the system. It was the body's own material. It had already been processed by the organs whose failure you were trying to reverse. It carried the signature of the interior. Returning it was not adding something foreign. It was returning something the body had already made. That logic had names attached to it. The Roman encyclopedist Pliny the Elder, writing in the 1st century, described urine applied to wounds and irritated skin as a treatment already in common use, noting its long practical history before his own time. The text was not fringe. Pliny's natural history ran to 37 volumes and shaped educated European thinking about the natural world for well over 1,000 years after his death. The Greek physician Galen, whose influence over Western medicine lasted from the 2nd century into the Renaissance, built a framework of humoral intervention so comprehensive that physicians working inside it had very little conceptual room to call any bodily substance simply waste. The Sushruta Samhita, the ancient Sanskrit surgical text compiled sometime around the 1st millennium and still referenced in the history of surgery today, cataloged urine among the substances with therapeutic application. The Ayurvedic tradition that grew from texts like these included what practitioners called Shivambu, a Sanskrit compound. Shiva meaning auspicious, Ambu meaning water, not metaphor. A formal category of practice with its own rationale and its own internal rules about when and how to apply it. All of these systems disagreed on specifics. They disagreed on almost everything actually, but they shared one foundational assumption. The body's own fluids were not neutral. They carried information. They carried force. And a substance that carried that much information about the interior of a suffering body was not obviously something to throw away while the patient was dying. So when the surgeon told you to drink it, he was not improvising. He was working inside a structure that had been built by careful, serious people over 2,000 years. And the part that is harder to dismiss than you would expect is what appeared to happen next. Because sometimes it appeared to work. Not always, not reliably, but often enough, in enough different rooms across enough different centuries that the people watching could not simply file it away as failure and move on. And that persistence is not stupidity. It is something more precise than that. Start with the dehydration, because that is the most honest case. You have just been through surgery. You have lost blood. The room was cold, but the procedure was not, and your body spent itself keeping your heart moving while the cutting happened. The thirst afterward is not ordinary thirst. It is the kind that comes from the body signaling a deficit so large that the usual options have run out. Clean water in a medieval surgical recovery room was not always available in the volume needed, and what was available was not always clean. Urine is, at the point of production, largely sterile. It is 95% water. The urea and dissolved salts that make up the remaining fraction are present in concentrations low enough that a single moderate intake does not immediately worsen dehydration. Drinking it once in the acute phase of fluid loss would have delivered real water to a body that needed water urgently. The patient would have felt the relief. The physician would have seen it. And the substance would have received the credit. This is the mechanism the physician missed and the one that explains the record. Not magic, not humoral realignment. Water returning to a body that had shed too much of it through the most available vessel at hand. But the record does not stop there, and neither did the practice. Urine was applied to wounds, packed into them, used as a rinse across damaged tissue after the knife was already put down. And here, the explanation requires more care. In 1867, Joseph Lister published his work on antiseptic technique, demonstrating that contamination was the mechanism behind post-surgical infection. Before Lister, before germ theory settled into practice, the interior of a wound was an environment that surgeons managed almost entirely by intuition and tradition. What they knew from watching was that wounds left fully open to the ambient air of a surgical room frequently became infected. What they knew from watching was that covered wounds, rinsed wounds, wounds kept wet with something, sometimes did better. Urine had urea in it. Urea in high concentrations is genuinely antimicrobial. The concentrations in human urine are not high enough to reliably sterilize a wound, and the American Chemical Society has noted in lay summaries of urea's chemistry that the dilution present in normal urine falls below the threshold of meaningful antimicrobial action. So it did not work the way Pliny or Avicenna or the Sushruta Samhita imagined it worked. But the rinsing itself may have mattered. Washing debris from a fresh wound with any fluid reduces contamination. The urine was incidental. The irrigation was not. The physician watching this did not have the conceptual vocabulary to separate those two things. What he saw was urine applied, wound improving. The attribution was wrong. The observation was real. Now place the grimace beat. Because the honest answer to why desperate measures looked rational is not about urine at all. It is about the alternatives. The post-surgical environment in a pre-Listerian hospital was a place where the most common outcome of a major operation was infection. So aggressive, it became systemic within days. Mortality rates for amputations in major European hospitals in the mid-1800s, shortly before antiseptic technique arrived, ran between 40 and 50% in some institutions. James Simpson, the Scottish obstetrician, calculated in 1869 that a soldier had a better chance of surviving a battlefield wound than a hospital one. That sentence stayed. The hospital itself was producing death at a rate the wound alone had not guaranteed. Against that background, anything that appeared to interrupt the chain of infection and fever looked like medicine. It was not that the physicians were ignorant of death. They were surrounded by it. They were looking for levers, and they pulled everyone they could find. So the person who told you to drink it was not a fool operating in a vacuum. He was a person standing in a room where the alternative treatments had already killed the last several patients, working inside a theoretical framework that had 2,000 years of internal consistency behind it, watching a practice that produced visible outcomes and crediting the substance rather than the mechanism. That is not delusion. That is observation without the tools to complete it. What actually worked was the water, possibly the rinsing. Not the urea, not the humoral realignment, not the return of the body's own auspicious fluid to its source. The thing that worked was the most ordinary thing inside the practice, the part that required no theory at all. And the belief persisted because the ordinary thing was real enough, often enough, that the extraordinary explanation riding alongside it never had to answer for itself. Picture that body again, the one on the cold stone table from the opening of this, the one that has just been through something the word surgery cannot fully carry. It is frightened in the specific way that only physical helplessness produces, the kind that makes the rational and the irrational collapse toward the same point. It will try what it is given. It will believe what appeared to help. And the people watching it, trying to save it, will believe alongside it, because belief and evidence were never as far apart in that room as we find it comfortable to imagine now. The lesson is not that they were wrong to look. The lesson is that they were looking carefully, with the instruments they had, at something real. They just couldn't see all the way to the bottom of what they were seeing. Neither, usually, can we.